Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. In episode 1 of this 2-episode series, we focus on a discussion of early treatment of hepatitis B. Which patients should we be treating? By Dr. Paul Kuo from Stanford University School of Medicine, Dr. Ira Jacobson from NYU Langone Health, and Dr. Tatyana Kushner from Icahn School of Medicine at Mount Sinai. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. Now, let's get started and hear Dr. Kuo pose a question about updates to hepatitis B screening and how this will affect the approach to treatment eligibility.
So, as you know, the CDC recently recommended now no longer risk-based screening, right? We're now doing screening those above the age of 18. There's a triple panel now that they've recommended, and we should be vaccinating these individuals as well. So when we see this, Ira, how do you think this is going to impact, just based on other screening guidances that have been released, how do you think this is going to impact the number of patients that we're going to be seeing and how this is going to affect our approach to eligibility for treatment?
Broadly speaking, Paul, I do think that if we expand our treatment guidelines or recommendations, it'll put a little less of a damper on being aggressive about identifying the disease in the first place. Now, I'm not saying that I know of any physicians or caregivers who say, well, the guidelines are too complicated and too nuanced, so I'm not even going to check for hepatitis B. But I do think the field would advance in terms of getting more people on treatment, and it's just a concept I'm putting across if we simplify these guidelines. Did I answer your question?
Yes. So you think as we simplify guidances, even more people will embrace screening as well?
They'll certainly treat more, but I think they'll screen more as well.
Tatyana?
Yeah, and I also think that it's actually necessary because now, since screening is recommended for everyone, there will be more screening in the primary care setting. And so we really need to have a simple message about treatment, right? Not all these patients that will be screened in primary care will have an immediate referral to hepatology who knows all the 5 different guidelines and makes a decision. So I think if we have a more simple message of look at the viral load, start treatment, that's much more straightforward and will lead to less people not being treated that really should have been treated.
Yeah, I think that's an excellent point. And if you look at the guidances, again, they account for rigorous follow-up. In the US and worldwide, not everybody can be treated by Dr. Jacobson and Dr. Kushner. And I think, here and in this audience, we have people who are going to be meticulously following these individuals, but many of these individuals won't go to subspecialty care. And I think that's another major impetus to simplify guidances. This was particularly true, I thought, Ira, and I just wondered about your comments. So you showed us this fascinating data about outcomes in hepatitis B patients in the indeterminate phase. And what you saw was that you started seeing clinical events, but these events actually happened not at 5 years, but it went up at 10 years. And then at 15 years, it went up. And you just wonder how much of this is just poor luck in the indeterminate phase and how much of it is that those who are treating them, these individuals, perhaps they weren't quite as engaged in care.
Yeah, and every study has limitations. The editorialist for the second paper I mentioned that just came out highlights them very, very well. And those are some of the limitations of these studies. They're the best we got right now. I think the reason that the numbers diverge over time is oncogenic events. They take a long time. But there could be some of that as well.
And I think the other point is that the HBV DNA, the viral load, and the ALT, they're not very static tests, right? The HBV DNA can fluctuate a lot. You see patients maybe twice a year. At that time point, you say, they're indeterminate, so I've put them in that category and I won't treat, or I will treat. But the reality is that many of these patients are fluctuating between phases. They're not always indeterminate, and perhaps it's those patients that actually do have higher viral loads and elevated ALT at times that you're simply not checking.
Right. And so let's now talk about a patient you see in clinic. And let's say that they're 30, their first diagnosis of hepatitis B, and Ira, they've come to your clinic, and they push back some on treatment. How would you approach somebody like this as far as further follow-up? Why don't you just outline what you do in your own clinic?
Well, the vigor with which I push back depends on the how strongly I feel that they're making a big mistake. So what kind of patient are we talking about? If we're talking about somebody who doesn't meet the criteria?
Somebody with a family history of cirrhosis and may have had a family history of liver cancer, they're not sure.
So I cite to them that a person with a close family member who's had HCC from HBV has a 2 to 3-fold risk themselves if they have hepatitis B. And we need to know what genetic factors are involved there. That's a very important question. But I push back pretty hard. If it's a patient whose ALT, who has a normal ALT level and a viral level of 4,000 and a normal FibroScan, I don't push back so hard. I say, you're within the bounds of the guidelines. I think those guidelines might change. My understanding is the very esteemed president of ASLD just an hour ago actually made a plea for simplified guidelines, having written them herself a number of years ago. And I think we all agree on that. So again, it's very variable. It's like an accordion, goes in and out depending on the vigor with which I feel they're making the mistake.
And I think I share with patients exactly about the types of discussions that we're having here, that we have the guidelines and you may not fit criteria based on current guidelines, but actually the field is evolving and you're seeing these newer guidelines and we're seeing newer data that suggests that we should expand treatment criteria. So even though it's not in the guideline yet, we're moving in that direction. And really these medications are low harm, low side effects, so they can only benefit you, right? And so, just kind of reframing the question from, I don't want to take another medication to, well, there's actually potentially a benefit, and the whole field is evolving towards really a more expansive treatment recommendation.
One more factor here, Paul, if I can interject it.
Yeah.
Young people who are highly viremic have a real social stigma attached. So they attach it to themselves. I just went through this with a patient the other day when I asked, are you limiting your social relationships? The answer was absolutely. And I had to deal with that. So that's another element to bring into the equation. Now, I admit the patient you're postulating who's already pushing back may not care that much about that, but that deserves to be explored too.
Sure. And I think we're going to need efforts to reduce stigma with this disease, as we will with other diseases, as we have in our treatment. If we had a treatment, let's just say hypothetically, rather than a suppressive treatment, we had one that cleared surface antigen 90% of the time. To say we had success like we do with our direct-acting antiviral agents, would you be offering treatment then universally?
And would this be a finite treatment?
Yes, finite treatment.
Absolutely, right? What we've seen with hepatitis C, it's so rewarding for the patient and the provider to be able to cure a virus, a disease that has potential to lead to cirrhosis and cancer. So absolutely, I think the message would change. And even now in clinical practice, I do speak with patients about, these are the medications we have now, but we do have new medications that hopefully will be coming in the coming years where it will be a finite treatment. So you may not need to be on this medication for the rest of your life. It may be for a number of years, but probably not forever. And hopefully we will have a finite treatment. And I think that really changes the conversation.
Agree. And I think that we can take a two-pronged strategy. Tatyana is going to share with us some exciting data where you're starting to see functional cure rates now that are above what we've seen historically with interferon and with our nucleoside analogs. And I think as the cure rates go up, we have a dual-pronged approach here. We need to suppress to reduce morbidity and mortality, just like we do, just like the WHO says, again, where we're trying to reduce viral hepatitis as a public health threat. And so we can pursue both of these goals and hopefully reduce morbidity and mortality while pursuing long-term functional cure. Ira, if the functional cure rate for a finite duration was 40%, 30%, would you be offering that to each person?
It really depends on the morbidity of the therapy. If the therapy were not particularly morbid, sure, but that's going to be very nuanced. I've sat at advisory boards in the past, and the experts converge around one number when asked, would we ever use interferon again with an antiviral if it gets you to a certain number?
Yeah.
What would that number be? And the answer, in most of the experts I've encountered, is about 30%. But I think that's also nuanced because it depends on how long you're talking about. I think a lot of us don't want to hear about 48 weeks of interferon, although it proves to be necessary. It might be a viable entry in the field. But 12, 24 weeks, particularly if the 24 weeks works better than 12, something we can talk about.
It's still, though, I think a very challenging discussion depending on the patient because, hepatitis B for the most part is asymptomatic. They are feeling fine. They're working. They have a full life. And to kind of say, well, we have a finite duration, but it's 24 weeks or 48 weeks, that really can interfere with their lives. And so, they would really I think the other aspects would really have to play a role in the discussion. I mean, the stigma piece, the potential for a cure, even if it does take some time. So we'd have to, it would be very nuanced discussions, but I think still not all patients would agree to it.
Agree. How does the conversation change, Tatyana, when you sit down with women of childbearing age and you feel they need to be treated? Sometimes I know we get a little bit more pushback in those settings. And how have you handled these situations?
It's a great question. And in particular during pregnancy, but also women of childbearing age who may be considering pregnancy in the future. And I think we've had actually a similar discussion about treatment of hepatitis C during pregnancy, which is much more controversial. But with hepatitis B, we have great guidelines. We have clear recommendations for which subgroups of patients should be treated during pregnancy in order to decrease the risk of perinatal transmission. But still, I have patients that say, I don't want to take a medication during pregnancy. I don't want to take any medication during pregnancy. And so sometimes, you really have to, I think sharing the data, sharing what we know, that there's a risk of perinatal transmission, taking this medication with your high viral load will lower that risk, and sharing with the patient the benefits. But even in this context where there's a risk of transmission to the baby and they can develop chronic long-standing hepatitis B, there's still hesitation among some patients. You really kind of have to have repeated conversations with them to get them on board sometimes.
Agreed. Thank you so much. Ira, what about some patients will say, what are the long-term consequences of these therapies you're recommending, these nucleoside analogs? How do you approach that, and what do you discuss with them? Do you discuss bone safety? Do you discuss other areas? What's your general approach?
Well, the first thing I say, because I'm an advocate for therapy and also want to be truthful, is that with every year that goes by, the treatments seem increasingly safe. I acknowledge that we had study concerns early in the evolution of this field. Of course, if you're going to give tenofovir, you have to talk a little bit about bone density issues and kidney issues. I think they're certainly in my experience in the literature, they've been relatively infrequent, though they need to be monitored for. The bone issues more in some patients than others, like people who are getting older, or postmenopausal women, for example. But I present it as all very manageable, and that it vastly outweighs the disadvantages of letting somebody who needs treatment for this infection go untreated.
Okay, yes, and generally you get reasonable acceptance with that as you move forward.
Yeah, the advent of TAF has made it easier to have the discussion about bone and renal issues as well.
I think sometimes the hesitation on the patient side is just the idea of being on a medication long-term, even not thinking about the long-term consequences, but will I really need to take this medication for the rest of my life or for long-term? And I think it's hard for some patients to get past that for a condition that's asymptomatic and they don't truly feel will cause any issues. And I think in that context, you frame it as, well, many people take medications every day for many conditions, even multivitamins, right? So yes, of course, I understand that, you don't want to take many medications, but if there's benefit, even if it is long-term, I highly recommend it. But if they are truly not on board, then you really can't force it on them, because if they start and stop and start and stop, that would not be a good situation.
And when they do decide not to be treated, you have to be empathetic and show them that you respect their decision and that you still want to remain engaged in their care. And it's not rare for me at all to say, you know what, we'll continue this dialogue in 6 months when I see you again.
So you get somebody who agrees to go on treatment. They come back 2 to 3 years later and they start asking, okay, how long am I going to be on this now? Okay, Tatyana, how do you, which is the question I get.
You say, I told you, long term. But yeah, I think they forget that aspect, but sometimes. So, I think that in our next discussion that will have some relevance, but like Ira said, if they really feel strongly that they really want to stop the medication, you have to the very least, do everything you can to try to assess their disease state at that time, give them as much information as possible about potential prognosis and risk if they stop, and make that decision together. And if you truly feel, based on different factors, that there's a high risk of flare, or that, for example, their disease has progressed and now they have advanced fibrosis, then in that situation, obviously you have to be a little bit more forceful about the need to stay on.
Do you ever use anything periodically assess these individuals with, say, an elastography or some other marker of fibrosis just to help them move forward with treatment, either of you?
In our practice, we use a lot of elastography. I mean, it's like a vital sign. we have multiple machines in our practice, so we do it really probably in many patients on an annual basis. Not that it's required, but I think patients like to see if there's been any progression or that there has not been progression. Also, sometimes we detect that there's steatosis in addition to the hepatitis B, so that also helps with the discussion. But we do it on a pretty regular basis. Ira, do you?
Ira?
Nobody walks into my office for a liver consult and doesn't get a fibrous at the first visit.
So
every new patient coming through.
It's the fifth vital sign?
It is the fifth.
That's very well said.
Yes.
I like that. And all of our patients are told to fast for 4 hours. It works about 95% of the time.
Right.
I still come in having ate lunch sometimes.
Right. And you're doing these on an annual basis?
No, I think a very well-controlled patient with long-standing hepatitis B and no prior evidence of fibrosis, who perfectly well-controlled in antiviral therapy, I can wait 2 or 3 years, usually 2 years.
2 years.
Yeah.
But sometimes the patients request it. The patients want to see it.
I find it's a positive reinforcement, and it's a way for them to say it's a reflection of good liver health. And particularly, it's almost more useful for steatosis.
Right.
Because we will see this interplay between hepatitis B and steatosis play out over the next several decades. There's much more to tell there. Your proposed treatment guidance, Ira, I noticed there was on the right side also one area that differs slightly from the current guidance. You said for hepatitis B cirrhosis, you just said surface antigen positive, you just treat. Does that mean even compensated individuals with undetectable HBV DNA, you would offer those individuals treatment?
I had a feeling you were going to get me on that. The guidelines, for the most part, say any level of viremia. I worry a little bit about reactivation in the occasional cirrhotic patient and the attendant risk of decompensation. So yeah, I usually do treat them. But I'll admit that that's a little bit outside the guideline, and I don't feel as passionately about that issue as I do about the rest of the things I said.
Well, so just so you know, the Chinese recently released guidance, which actually agreed with you. Mm-hmm. And they said also that compensated cirrhosis regardless should be treated. We actually published a paper, very interestingly. We looked at those with compensated cirrhosis, undetectable HBV DNA, and treated versus untreated, and we actually showed a higher rate of HCC in those who were not suppressed pharmacologically. We published that in Hepatology Communications. Mm-hmm. So it changed my thinking on the topic, and I now also suppress these individuals.
I thought the other interesting category in your guidance is the elevated ALT, but the lower HBV DNA. So you really have to rule out the other potential causes for the elevated ALT.
Especially HDV?
Yes.
But fatty liver disease? I mean, the whole gamut. Yeah,
right.
Absolutely. But if you ruled those out, you have nothing else to blame. There are occasional patients with low-level viremia who have some hepatocellular inflammation.
Yeah. So, Tatyana, let's just take somebody, BMI is 35, viral levels 1,500, ALT 70. Mm-hmm. Okay. They have a high CAP score. Do you ever decide that these individuals should be treated? Do you follow them longitudinally? We see a fair number of these individuals in our clinic.
Right. So, again, it's an individual discussion for sure, because based on the AASLD guidance, they wouldn't necessarily meet treatment criteria because their HBV DNA is less than 2,000. That being said, there is data that suggests that if you have both steatosis or MASLD with hepatitis B, you have more rapid progression of disease. So perhaps we should have actually a lower threshold of treatment, even if we think that most of the driver of the ALT is the steatosis. So I think I would have the discussion, and it would be a joint decision making.
Yeah, I have also offered treatment to some of these individuals as well. Sometimes difficult. Ira, have you found yourself in this situation?
Well, this is a topic dear to my heart because a few years ago I was privileged with the opportunity to work with Gilead and look at their database. Because if you ever look at the pivotal trial data from the tenofovir program, it's always about 10, maybe 15% of patients who clear HBV DNA, but don't normalize their ALT levels. And we found actually looking at longitudinal liver biopsy data, or well, maybe it was cross-sectional at the outset. Well, they did do longitudinal data, for example, in their famous cirrhosis study, that the usual answer was steatosis. So just a little tip to the group, which is that if you see your ALT not normalizing in patients on tenofovir, you all know this, think about steatosis. Of course, by then, if you've done your FibroScan and ultrasound that I think we would also advocate, we haven't talked about HCC screening yet, you already know they have steatosis. But it was a nice kind of coming together of observations that have been made historically.
Right. Very good. Thank you so much for this discussion.
I'd like to thank Dr. Jacobson, Dr. Kushner, and Dr. Kuo for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and the full program on time to move the goalposts, examining strategies to advance HBV management, on the Clinical Care Options website, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.